Thank you for the introduction. Good afternoon, everybody. There's my potential conflict of interest. During the next 20 minutes, I will address my topic by touching the following subjects: high cutoff membranes as a blood purification therapy, some technical evolutions in the manufacturing of the membranes, the definition of high cutoff, cytokine clearance, and some clinical data from the literature. If we look at this paper published 20 years ago and citing another paper published 25 years ago, we can see that the use of hemofiltration as a new therapy for sepsis, an adjuvant therapy for sepsis, is not a novelty. But the questions are still the same. Which filter, the timing, the dose, and so something is really changing recently with the new membranes. And these membranes are identified as instruments for blood purification in septic patients, mainly in acute settings. And you have already seen these slides by Professor Antonelli before. What do the surviving sepsis guideline tell us? There is no recommendation for blood purification techniques in a modern approach to sepsis, and the reason is that the trials are still small, unblinded. There is the risk of bias, but they also state that there is no evidence either in favor or against blood purification therapies, and there is a big space for new research in the next future. And during the last years, we have seen a huge improvement in technology in CRRT, especially about monitors, circuits, pumps, new anticoagulation approaches, and so on. But also the membranes are changing over time, probably versus the chronic treatment. I don't care about chronic dialysis, but I think that in chronic patients, there is a much more tailoring of treatment for the patients respect the acute setting. But these new membranes have some specific characteristics. This is a very beautiful picture published by Professor Ronco and Professor William Clark very recently. This is the first hemodialyzer structure published in 1944, and the more modern hollow fibers was born in 1970s. And the membranes may differ from a lot of points of view: the inner diameter, the thickness, but also this layer, there is the skin layer, less than 1 micron primary size discriminating element in solute removal. So a very important part of the structure, and the stroma where absorption may happen, but also the roughness of the surface that may influence the protein layer, and so the ability to clearance the molecules, but also may influence coagulation condition. And the pore dimension and density and distribution is another critical aspect. Just to give you a very rough example, we may have few small holes, a lot of small holes, few big holes, or a combination of them. This picture well summarizes the distribution, very narrow in high flux membranes with the low holes, and the wider distribution with bigger holes for high cutoff membranes. And the effect on clearance of molecules is clearly different. For example, if you want to remove myoglobin, you shouldn't choose an high flux membrane because the coefficient is very low, but very well with a high cutoff membrane. This is another picture we published recently in which it's clear that the holes are almost double as dimension in high cutoff membranes versus high flux membrane, and again the distribution is much wider. And with the increasing of solute molecule weight, the pore size limitation became increasingly important in restricting solute entry and limiting diffusion of molecules that gain pore entry. In other words, diffusion-based solute clearance ideally declines with increasing of molecular weight of the molecule you want to clear. From a definition point of view, we should take into consideration two definitions: the molecular weight retention onset, that is the molecular weight of a given solute at which the membrane sieving coefficient is 0.9, and the molecular weight cutoff, that is the molecular weight where the sieving coefficient is 0.1. And this is the distribution of the different membranes. And from a practical point of view, high cutoff membranes very well remove molecules from 20 to 60 kilodalton. And from a more practical or clinical point of view, we can say the high cutoff membranes describe membranes with a cutoff value that approximate the weight of albumin. You have already listened to this concept. With the membranes like this, we may push more than with a high flux membrane the elimination of middle molecule like the pro-inflammatory and anti-inflammatory cytokines, hoping to remodulate the immune system. These cytokines are very favorable with the cutoff membranes because they are water soluble and free of protein binding. And we could try to cut, as Professor Honoré said before, the cytokine storm in a pro-inflammatory phase, or to remodulate the anti-inflammatory phase. And you have seen a few minutes ago these slides in light of the new view of sepsis-induced or sepsis-associated AKI. The idea to remove the cytokines from the blood could help to avoid a sort of intoxication of the kidney. From the literature, we have some data with the chronic, but with acute treatments, clinical experience is still limited and somehow unclear. We have some study globally summarized in this recent review. The first study is published between 2003 and 2004, was by the German group of Morgera, were oriented just to understand if these specific membranes were capable to clear middle molecules, cytokines specifically, and which could be the effect on the immune system. The first clinical study by Morgera and co-workers was published in 2006. It was a randomized 2-to-1 trial in 30 patients. They observed an improvement in SOFA score within 48 hours of treatment with a high cutoff membrane, and at the same time a decrease in interleukin-6 and interleukin-1 receptor antagonists. And they measured the sieving coefficient that were close to 1.9 up to 24 hours of treatment, differently from the standard high flux membranes. And at the same time, they observed an improvement in hemodynamics, read as a maintenance or increase in mean arterial pressure with a progressive decrease in norepinephrine dose. The group by Haas and co-workers in 2007 published a double-blind crossover randomized trial in very few patients, but they again demonstrated a very good clearance of 3 cytokines, interleukin-6, 8, and 10. And the same group summarized the situation the year later by underlying the effective removal of cytokines with high cutoff membranes. But in most of the cases, we are still discussing about research models. Most of the cases, vasopressor therapy decreased, hemodynamics improves, but most importantly, there are no serious adverse effects. The group of colleagues I worked with in 2016 published a retrospective case control study in patients with MDR monomicrobial gram-negative sepsis. 16 patients, again, few patients, and 8 control with CVVH-DF standard treatment with high-flux membrane. What we observed was, again, an improvement in hemodynamics, reduction in vasopressor drugs, reduced in length of ventilation days, and a reduced mortality in the ICU, not confirmed from a statistical point of view as in-hospital mortality. The same year, Aiton and co-workers published another study, 14 patients. Again, they confirmed a good clearance of interleukin-6 and interleukin-8 with high cutoff membranes. But from a statistical point of view, they were able to demonstrate a statistically significant decrease only by putting cytokines together as an overall cytokine plasma level decrease. Last year, Gianluca Villa, my good friend and colleague, published this prospective multicenter study in patients with septic shock treated with high cutoff membrane in CVVHD with the Septex membrane. What we saw by dividing the group into survivors and non-survivors, a global decrease in SOFA score, but the decrease in SOFA score was positive and clear just in survivors, but not in non-survivors. And we discussed it, and we thought that maybe SOFA score could be, in these cases, an early indicator or probability of survival. Again, we observed a decrease of TNF-alpha, interleukin-6, and interleukin-10, but just in survivors and not in non-survivors. Albumin loss is a very frequently discussed issue with high cutoff membranes. This is the reason why the choice technique is CVVHD. Dr. Villa, with this experimental study, evaluate albumin loss with high cutoff in CVVHDF and citrate versus standard approach. He demonstrated that albumin loss during the single phase and during the circulation phase was not different in these two types of treatment. And so my conclusions on high cutoff membranes is that probably we have to do more studies, more data are necessary. Clearly, yes, they are very effective in removing molecules from 20 to 60 kilodaltons. Probably, yes, hemodynamics, at least considering mean arterial pressure and norepinephrine dose, seems to improve in almost all patients. Probably there is an inter-individual variability that we should take into consideration by designing the new studies, and probably other conditions, non-sepsis related, like liver failure, pancreatitis, or ARDS, in which we have a cytokine-driven mechanism, maybe could benefit from high cutoff treatment. Thank you.